Hi guys, welcome to part 2 of our Suxmethonium discussion. So now we know what Sux is. We know that it's the only depolarizing neuromuscular blocker that is out there, and we know what we mean when we say depolarizing. We know how depolarization occurs, and we know the structure. We know the enzyme that breaks it down. So now I want us to talk about the indications. When do we use Suxmethonium? Suxmethonium indications. First one, rapid sequence induction. Rapid sequence induction. If you have not watched, there's a video that I uploaded yesterday that goes into detail about rapid sequence induction. So please go and watch that. Maybe I'll just put it I'll just put the link on the comment section. So rapid sequence induction, it's also used for when the patient develops a laryngospasm. Which happens when a patient is, if you insert the laryngoscope or a tube, ETG tube, and touch the vocal cords that are not paralyzed enough, or if a patient has got a lot of blood there and anything that irritates the larynx can make it to go into spasm. Okay. It's also used for short procedures. For short procedures like ECT, this is done by the psychiatrist. I had an opportunity to see how it's done when I was a student, but it was in private. I don't know if it's done in public. And then also joint reductions when a patient has got a dislocation. Reductions. Basically, but the number one indication is this one. And people have been saying that if you cannot use Sux for whatever reason, maybe the patient is known to have migraine hyperthermia, or we're going to talk about conditions that cause upregulation and downregulation of receptors. But if you cannot use Sux, people have been saying we can use rock. And one other thing that I forgot to mention, Sux is rapid acting. It acts very fast and works for about, it starts working in about 30 to 60 seconds. Some people say 45 to 60 seconds, and it lasts for just under 10 minutes. Some people say 5 to 10 minutes. So that's how fast it works. So now what I want us to talk about is conditions that Sux should not be used. So what are the conditions where Sux should not be used? Okay, let's talk about we will call these conditions nicotinic receptor upregulating conditions, medical conditions. So things like upper motor neuron lesions, lower motor neuron lesions. Well, let's talk about this first. So why should SARS not be used on those patients? What's the problem? So these conditions, the patient is not mobilizing, right? Is not mobilizing. Now, if you're not mobilizing, your muscles, they atrophy because they don't get stimulus. And if they atrophy, you get upregulation of receptors, regulation of receptors. Okay, let's say this is a cell. It has got receptors. Let's say in this cell I've got about 40,000, let's say 4,000 receptors. Now this cell, if it happens that, let's say this cell and its receptors responds to drug A. If this patient keeps being exposed, so I'm trying to explain what is upregulation and what is downregulation of receptors. So if this patient is always exposed to drug A, it means you're going to have a lot of drug A that attaches to those receptors. Now, to avoid, up to a point whereby, let's say, up to a point whereby these receptors, some of them will start being endocytosed. They come inside like that. Now, when you do that, you will reduce the number of receptors. So this is called downregulation. I'm going to repeat it again. You've got a cell that has got receptors. These receptors, they bind, so drug A binds to these receptors, drug A. Now, if you always have drug A in your system, you're going to have these receptors, some of them being endocytosed and even being destroyed. And once you do that, you will be left with a few receptors now. So that's downregulation of receptors. Let's look at the opposite. You've got this cell, has got receptors like that. And these receptors, they are for drug B. If drug B is very scarce, or let's say if drug B is very scarce, what's going to happen is that this cell will start forming a lot of receptors so that whenever drug B comes along, they will maximize drug B. So this is upregulation of receptors. Upregulation of receptors. Now, let's get back to the issue. So we said that with upper motor neuron lesions or lower motor neuron lesions, your patient there is not mobilizing. They cannot walk. Whatever the cause, they cannot walk. their muscles, they atrophy, and what happens is that because they're not stimulated, these muscles, they want to be stimulated, they are longing to be stimulated. So what's going to happen is that the muscles will start expressing a lot of receptors, which are nicotinic receptors. A lot of those receptors are going to start to be on the surface now of the cell. Going to start to show on the surface of the cell. So that whenever there is stimulation, they will maximize the presence of acetylcholine. Remember, these receptors, these nicotinic receptors in these patients are not stimulated because they don't receive acetylcholine, because these patients have got they've got either upper motor neuron lesions or lower motor neuron lesions. So they are not used to acetylcholine, they're not receiving acetylcholine. So now what they decide is that, okay, since we have not been stimulated, we are not getting any acetylcholine, let's make sure that we express a lot of receptors on our cell surface so that the day acetylcholine comes, then we will maximize that. Now the problem is that if this patient has got a lot of this upregulation of receptors, so the day you give this patient scoline or Suxmethonium, that Suxmethonium is going to come and now attaching all of those receptors, and the effects will be exaggerated. The effects will be exaggerated. Now, the effects that will be exaggerated are, I should have discussed the side effects of Sux. I don't know why I forgot about it. It was supposed to come before this video. Now, basically, your hyperkalemia will be very hyper. Your fasciculations will be very exaggerated. We'll talk about these side effects, but this patient is likely gonna die from hyperkalemia. Remember, if a normal patient who doesn't have any lesion, they are walking, their cells, let's say they express about 4,000 receptors, they still develop hyperkalemia because of the Sux. How much more on a patient who's got about 20,000 receptors? Now, when the Sux come, it's gonna have an opportunity to sit on 20,000, I'm just making an example, on 20,000 receptors. This patient is gonna have the hyperkalemia that this patient will experience. But let's say the side effects of the Sux that this patient who has got upregulation will be much more significant than the one who just has 40,000 receptors that are expressed. This is the concept. This is why a patient who cannot walk, patient who's got a spinal problem, people who have got diplegia, quadriplegia, people who have been immobile, even if they don't have a spinal problem, they're just immobile, they will have upregulation of their receptors. So I hope you guys understand now what is upregulation and downregulation of receptors. Okay, let's talk about this. Okay, let me do it this way. Let me just finish with these conditions that Sux should not be used, and then we're going to talk about the. I made a mistake by not discussing the side effects of Sux. So upper motor neuron lesions, lower motor neuron lesions. The other one that they like to ask on this exam is bends. Bends. A patient will suffer bends. The issue with bends is that if you've got cells like that, and these cells have been bent, they release potassium. And that's why when a patient that's got bends, should be done in ABG to check how their potassium is doing. Because once cells are destroyed, remember, potassium is an intracellular cation. So when the cell membrane is destroyed, potassium is gonna leak out. So patients who have got bends, they have hyperkalemia, and Suxmethonium should not be used. Now the interesting thing is that some people say it should not be used up to a week, and then I've got a friend of mine who had a patient who works in anesthesia in East London. So he was like, he had a patient who had a step abdomen, I think, or an MVA, and that patient had bends about 2 years, just under 2 years ago. But that patient still developed hyperkalemia. So yeah, so I'm not exactly sure how long you should wait. But obviously, the more acute the bends are, the more you want to stay away. So that's bends. Then the other condition is, like I said, immobilization. When a patient has been immobile, patient who has been on the bed, patient who had a fracture, now it's been bedridden, patient who has been sick, now in bed. Those patients, they get upregulation of these receptors. So conditions like MS, multiple sclerosis, and muscle injury. Other patients that you should be, when you talk about muscle injury, okay, we're talking about something like crash injury. You know, when you've got crash injury, you get hyperkalemia already. Now the issue is that with bends and muscle injury, these two, they cause a lot of potassium to be released from the cells. That potassium, so this patient is gonna be hyperkalemic. Now you further give Suxmethonium, you are gonna worsen the hyperkalemia. So that's the idea behind these two. It's not that they've got upregulation, these ones, but it's because their conditions, crash syndrome and bends, they cause hyperkalemia on their own. And then what other conditions? Okay, Guillain-Barré, I mean, should not even be here because it's a neuronal problem. So guys, in the exams, make sure that you understand about these two, the bends, immobile patient, and crash injury. I think with that you should be fine. These are patients that there are other conditions like sepsis as well, like what else? I can't think of other conditions though. But yeah, so let's meet on another video where we talk about the side effects of Suxmethonium.